It's really wonderful that we have Dr. Per Nilsen to offer this webinar as the first webinar in the new academic year of 2025. And for today, we will have around 1 hour together. So I'll first take some time to welcome all of the participants because it's early in the morning and right now it's 9:02. And we might wait a bit for the participants to chime in and we'll officially get started around 9:05 a.m. Pacific time. And then I think currently all of the participants are muted, and then you can also test whether you can unmute yourself or not. Maybe Kirsten West, would you like to give a try to unmute yourself?
Yes, hello, can you hear me?
Yes, that's
Yes.
wonderful. Yeah,
Oh,
and regarding the logistics, we had a prior communication with Dr. Penelson, and he welcomes your questions for clarification. And then we will also receive a reserved 10 minutes for Q&A. So the structure of this webinar has been presented on the screen. And we will first get started with 5 minutes of the brief introduction of LAPIS, standing for Learning for Action in Policy Implementation and Health Systems, followed by 40 minutes of presentation by Dr. Per Nelson. And the topic will be on the challenges of behavior change. And Dr. Per Nelson is from Linköping University in Sweden, and he was trained as an economist, but he is leading one of the strongest implementation science program in the Europe. And we are also very thrilled to invite him for the visit of Seattle in person in spring. So we are going to organize several other events as well. And we're going to convey to you regarding how to connect with LAPIS to receive future information. Wonderful. We're going to get started. So as I said, first of all, we're going to use this opportunity to introduce Lapis to all of the audience, including Dr. Pernilson, because Lapis is pretty new. And I'm thrilled to make the introduction. And I also want to use this opportunity to appreciate Rianda and Kuko, who has been supporting Lapis in organizing this webinar as well as preparing the slide deck. What is LAPIS? LAPIS is standing for Learning for Action in Policy Implementation and Health Systems. I know it's pretty mouthful, and we established it in a way, try to really facilitate the policy implementation study. And here is our stated mission and vision. So for the Department of Global Health at the University of Washington, we are very strong in vertical programs such as HIV/AIDS, malaria, tuberculosis. And for LAPIS, we want to support effective implementation of those programs at a scale through new research and training activities. And we also want to emphasize cross-cutting topics rather than the disease-specific programs, such as health system strengthening or integration of different programs, such as family planning and primary health care. We also want to strengthen the collaboration and mentorship programs. At UW, we have the PhD in implementation science, and this is one of the earliest doctoral program in implementation science. In addition to that, we also have a Doctor of Global Health Leadership program. And over time, we want to become a leading institute in policy implementation science and respond to the country partner request to focus more on health system strengthening. And for us, we identify our efforts in 4 pillars. The first one is really about health equity to improve the access and quality of healthcare services and also influence the global primary healthcare as well as universal healthcare agenda. And the second one is really to respond to the needs of our partners, such as Ministry of Health, and to help determine the research agenda. For example, currently for our department and also for David Watkins, the co-leader of LAPIS, has been working extensively on identifying the opportunities to determine the design of the benefit package in many countries. And we also want to work on the system level in thinking more creatively about the innovative financing strategies, as well as new topics such as non-chemical diseases, health security, digital health, etc. And we also want to really think about maintenance and sustainability in policy implementation, really go beyond the pilots and really want to identify how and why some programs succeeded in long term. And we identified four strategic areas of focus. The first one is policy implementation science, extended to the low and middle income countries. And the second one is really working on methods for health policy and system research. David and I has been working on modeling, especially about those models which are less data hungry and more accessible for the low and middle income countries. We all know that currently most of the microsimulation models are very costly. Maybe each model might cost more than 1 million US dollar or even more. And currently we are in the process to think about the low cost models, which would be maybe around 50,000 per model with visualization, such that we can use those models to guide future policy planning. And we are also exploring the new methods, such as the coincidence analysis for future policy analysis. And then for health system transformation, we have been working on digital health, integrated primary health, etc. And we also are really dedicated towards training and capacity building. So besides me, David is another leader, and both of us are the co-founding directors of LAPIS. And for LAPIS in the past years, we have been focusing on identify the contributors to a collection called Learning for Action in Policy Implementation. And there were 12 papers contributing towards this collection. And hopefully the editorial will offer you an overview about the collection. And it was really wonderful to have both qualitative and quantitative research in this collection, in addition to the policy briefs and other different kinds of the articles contributed towards this one. And another thing we are very excited about is a new collection through the Nature Portfolio Journal with a focus on policy implementation in health financing and service delivery. We just opened the submission in September last month, and then the submission will due in early June. And we are also going to offer the merit-based as well as a need-based publication fee waiver, because currently for Nature Portfolio Journal Health Systems, the publication fee might be around $3,000, and some of the institutions, they do have the institutional discount. And then for us, we could communicate with the editorial committee to waive your publication fee. So if you are interested in this opportunity, please feel free to reach out to me. And then if you scan the QR code on the left, that will lead to the website of LAPIS, and feel free to reach out to us through lapis@u.edu to add to our listserv, such that you will receive information about future activities. And then without further ado, we're going to have Dr. Per Nilsen to present his study, and then we will also reserve 10 minutes for Q&A. Thanks, everyone. And Dr. Per Nilsen, the floor is yours.
Yeah, thank you very much for the invitation. And now I need to get this technical things to work.
Take your time. Yes, we see the presenter view. That's perfect.
Okay, so I need to move this so it doesn't obstruct my slides. It's fine. Okay, so very much thank you for the invitation. And as we said, I will visit you in April after discussions with Yanfang Su. So, and this session will concern the challenge of behavior change, which I think is sort of cross-cutting. It applies to implementation science, but it also applies to much intervention science, intervention research. So briefly, my background, because you already touched on some, I'm sort of a mix of between an economist and psychologist. It's usually called behavioral economics today, and also various work and writing various things. But I've been in Linköping since the 2000s. 2006, my thesis was on injury prevention, which is an area of research I haven't really continued. Instead, it has been much implementation science. And I'm really actually quite proud of this course we are giving, because we've done it for 15 years, and it's very international with we haven't had from the US, but we've had from India, Australia, South Africa, and most of Europe. And it's hybrid, so people can participate via Zoom and also on site. And I'm also doing research on AI implementation. So yes, Linköping University, I had to check up on how many students there were, because I thought it was like 20,000, but it's actually the double, so it is quite large. And Linköping is 2 hours away from Stockholm, from where I'm originally. And yeah, it's been 50 years today, so it's not very old. And its focus is on technical sides, but we're also, I think, quite strong in medical technologies and things like that. But also think the implementation research is fairly strong. We are not that many, but those there who are doing this research are quite active. And what will I talk about? 4 perspectives on behavior change, because I think it really matters how you, what perspective you apply. And then a tool to analyze conditions for behavior change. And it's a very simple model, but it can be quite useful to consider if you are involved in work where the ultimate goal is that behaviors need to be changed. This model can be quite good. It can be useful for thinking through what characterizes this setting or this environment where you want to introduce or achieve behavior change, and then some wrapping up. And we talked about 10 minutes of Q&A, that's fine. And you can also interrupt if I can see it, but otherwise maybe Jan Fang can tell me to stop and respond to questions. So the aims here are to achieve, I'm very much in favor of trying to achieve improved understanding of issues. And here it is how behavior change can be explained from 4 perspectives. And I think this is important because the strategies we apply in implementation research or implementation practice they depend quite a bit on what theoretical perspective we apply. So the 4 perspectives, and I have to check my watch now and then. It's getting quite dark here, actually. Fall is coming. So behaviorism is not new. It's over 100 years since it was the early studies were done. And what I'm going to address here is the operant learning principles, which are very much applicable in implementation research, probably also in policy implementation research. And the key principle is that using reinforcement and punishment, you try to achieve the behaviors you're after. So it's really like how you, train dogs or whatever. Trying to reward some behaviors. And this is very much done through financial incentives. They are essentially a strategy based on this principle. So an implication here of those principles use implementation strategies that reinforce the behaviors that are aligned with an evidence-based practice and punish or avoid rewarding undesirable behavior. So it's a very seemingly very basic principle. And I went through this ERIC, which is really the key source for implementation strategies. And then maybe I should also emphasize that implementation strategies are what we will usually call interventions when we talk about clinical research. But in clinical research, these interventions target patients or possibly populations. But in implementation research, we call them strategies, and they target healthcare providers, healthcare teams, organizations. So it has a different analytical level. And they're called strategies primarily to differentiate them from the interventions in clinical research. But in this taxonomy, ERIC taxonomy, which is widely used and highly respected source, it talks about providing financial incentives or disincentives and providing feedback. And these are, you could say, based on behaviorist principles. And they work well, I think, financial incentives in the short term. Because there is an issue if these incentives are taken away, what happens then? We have many examples of behavior change happening when there is a financial incentive, but when this incentive is withdrawn, it might be difficult to maintain those desired behaviors. But if we move on, there are limitations of behaviorism. It does not account for the cognitions, the mental processes, is essentially concerned with behaviors and cues and responses. So in the 60s, we talked about the cognitive revolution, where we emphasize exactly what behaviorism neglected or did not concern itself with. The processes between the stimuli, and stimuli here could be on the clinical guideline, for example, and responses, which could be the behavior aligned with an evidence-based practice. So a key principle here is that we sort of assess or weigh the pros and cons of carrying out the behavior, seemingly very and maybe not always so realistically rational. But these social cognitivists within a number of theories are widely applied still in implementation science and definitely in intervention research. And here are some examples. As you can see, there's a number of factors influencing the ultimate behavior. This is one of the most acclaimed theories here, social cognitive theory, Bandura. Another is theory of planned behavior, and they are essentially quite similar, usually with intention or motivation as the most proximal predictor of behavior. So the implication here, if we take this, assume this perspective, then you should use strategies that address these factors, attitudes, beliefs, motivation, self-efficacy, which is the belief in one's capacity to carry out a specific behavior. And there are many, I would say, the bulk of strategies are based on these principles, usually some education or training. And we also, in this ERIC taxonomy, talks about clinical supervision and also preparing patients to be active participants. But I think the sort of default strategy in implementation research is some form of training education. And that is probably sometimes required when knowledge is lacking, but it might not always be the most efficient strategy. But there are also limitations to this perspective. It does not account for the non-reflective, non-conscious processes. And I found this quotation, which in a book about health behavior change, that this approach, this perspective has taken a theoretical battering in recent years, and that's because of dual process models. And they were existing before the 2000s, but it's really in this century, the last 25 years, they have taken on a great, gained a lot of attention and interest, and even the Nobel Prize in Economy for Daniel Kahneman. And here the principle is that, well, we do have this cognitive system from the social cognitive perspective. However, we also have the system one, where we are more sort of automatic, relying on habits, being intuitive fast, and this saves time. However, if we are doing things based on the system one, that is very habitual, it could also mean that this behavior could be very difficult to change. So I think dual process models have refined or complemented the cognitive perspective by putting more emphasis on the system one. And there are different variants of dual process models, but essentially more or less the same. And it's a very popular topic, habits. So I think it's a sort of, I wouldn't say new, but fairly recent recognition that behavior change, well, we might be very motivated and have the capacity and skills but it could still be very difficult to make the behavior change. And that goes for also breaking habits and creating new habits. And I think this from nursing is very similar, the idea of the novice to expert theory, where we start in a job or a task as novices, and we rely on more written texts and sort of being very, I would say, cognitive or very rational, probably quite slow. And then we go through this process until we are experts. And being an expert here, the intuitive grasp seems very much like system one. So we are efficient, but we also have these habits which might, if they are unwanted, can be difficult to disrupt. And I think this is very difficult to sort of measure and specify, but it's worth considering how much of what we do is probably habitual. And I've never seen a paper on this, a study on this in healthcare or other contexts. It could probably be more. But I think it would be difficult to measure, as I said. But it's still thought-provoking that we are not as sort of conscious or rational that we might think. We are also quite habitual. And a colleague from England, Newcastle, Sebastian Pothoff, did his thesis on habits, what the role they play in healthcare. And he concluded that if we do frequently perform behaviors, the more simple ones, because we have done them, we have become experts in them. These are more likely to be driven by the non-conscious process, i.e. system one. But if we do something that we are not familiar with or something we don't do so often, something that is very complex, he concluded that then we are much more likely to rely on system two. So this is research, even though it was limited empirical examples, really suggests that this system one and system two and habits are very much relevant also in a healthcare setting. So the good thing, habits make us efficient, but they can also, we sort of put on blinders. So we have a reduced ability to detect deviations and changes. And information inconsistent with the habit is more likely to be ignored. And that's why all these signs that we put up, we might notice them the first few times, but after that, they sort of become part of the context of the surroundings. And I don't think they influence our behaviors that much. We don't see them after some time. So disrupting habits can be quite difficult, and this usually do not work. Just telling somebody that you should do something might not be sufficient. I think this probably is more efficient, creating a novel situation, and I think unusual example, but from traffic, when we're these road bumps, they force us to slow down. it creates a situation where we have to, if the habit is driving at a certain speed, this forces us to slow down. And reminders could be something similar. And we also have the option of creating discrepancy between expectations and outcome. Getting feedback on performance might be an eye-opener, or disrupting a habit. So an implication of this perspective, well, we have to be aware that some behaviors that we want to change could be habitual, thus very difficult to change, and maybe information is not the most efficient strategy. And what strategies does the ERIC taxonomy feature that applies to this perspective? I could find a couple, quite few, but the reminders we talked about, and intervening with patients to enhance uptake and adherence, that they get appointment reminders could be one. Or so I think the habit perspective is not as well represented as especially the social cognitive one. However, there are also limitations to this perspective, because all the three ones we have talked about ultimately essentially consider individuals as autonomous, independent decision makers, that we are sort of very actually very individual. We make our own decisions. However, we exist in an environment of colleagues and a culture. So Edgar Schein, leading organization and culture scholar, this is another sort of estimate or idea, I would say, to emphasize that we might consider that we are not as individualistic as we might think, because he says that so much of what we do is driven by culture. And culture is the norms, values, beliefs, assumptions we have. And they are learned and they are shared in different groups. And a group could be a department, it could be a profession, a team. And I think in healthcare, at least, professions have their own cultures. So it can have a very strong influence on people within a profession. Even though you might have individual differences, being part of this profession, you might be very inclined to follow your colleagues. And to illustrate this distinction between being individual or collectively influenced, in a weak situation, you have little pressure to perform. And I guess in Sweden and US also, you might be more inclined to walk against a red light, but you might be less inclined to do that in a strong situation where you feel the pressure from your surroundings to behave in a certain way. So the question is how weak or strong the situation is in the settings, environments you do the research. I think it's interesting that this whole thing about evidence-based medicine, evidence-based practice, and evidence-based everything essentially, is that it was the idea was to convert weak situations where everybody does like he or she wants, to being more standardized. So converting these into strong situations where we follow guidelines to achieve an evidence-based practice. This is a very commonly used framework in implementation science, and I think it's interesting. I highlighted that it only has three factors or domains, they're called here, that show the collective influence. Everything else is more individual, like optimism or intentions, goals. So this is a good example of a theory or framework that is from psychology, where the more focus is on the individual's own actions. However, it's also important to emphasize that these collective influences can become non-conscious over time. So we act without much consideration, like, for example, how our colleagues are acting. And this is also a topic that there is interest from a sort of popular science perspective. So culture has been studied a long time ago. I think organizational culture is the maybe most applicable to implementation science. But as I said, it's something learned and it's something shared. And it doesn't have to be, I mean, internet communities could be considered having different cultures and a family. So as long as there is a social group, it could be a different culture. It's collective phenomenon, and it develops in any social group. And leaders are important culture creators. But culture also influences who become leaders, so they are sort of interdependent. And I usually show this to emphasize that what's beneath the surface is often what determines our behaviors. What is above the surface is what we sort of put into writing, and at least in Sweden, we're sort of very structured, organized, and have policies, procedures, everything. That's all fine if they are aligned with what's beneath the surface. And they are not always. So an implication of this perspective is that, well, current behaviors might be collective. The people might in a survey say that they are for or against something, but in actuality, they might act more aligned with their own profession or another social group. There are a few strategies, sometimes difficult to research, I think. Identify, prepare champions. Champions is someone who would advocate and support the implementation of a practice. Recruit, design, designate, and train for leadership based on the idea that leadership influences culture. So there are some strategies which are based on culture principles. Then 9 minutes to go through this. A tool, it's quite basic tool. And we have on the horizontal level, we have individual level to one side, influences, and more collective. So you could say that on the collective side, we can talk about culture being the influence. And on the vertical axis, we have upwards something that's very consciously cognitive processing dependent, and below it would be more on the habitual system one side. So if we're looking at practice settings, if diagnosing something diagnosing a condition which the practitioner is unfamiliar, that would be the combination of cognitive processing because she's unfamiliar with the practice, and on the individual level. Here we would have something that the person is very highly familiar with, so it would be more habitual. And then we have this challenging, we did a study on patient safety in healthcare, and we found this culture of silence, which was that doctors reluctantly talked about making mistakes, even though the patient safety is very much based on if you share your mistakes or mistakes, others can learn from it. So you can go from individual learning to organizational learning, but they were hesitant or reluctant to talk about mistakes. And so, but they recognized that there was this culture of silence, and they sort of regretted that. It was quite interesting. So this would be a more conscious, they were conscious of this, but it was definitely a collective phenomenon among doctors who are trained to be experts in sort of not making faults. So it was, what we found was this, we called it culture of silence, not talking about the mistakes you make. And down here we have quite challenging examples where the person acting like this are not aware of their bias or that they act on stereotypes. So they can be difficult to change, but through probably being informed that this is the case is one way. And what strategies are relevant? Here, it could be probably information, knowledge, training, etc. The sort of default strategies, because that would probably remedy these faults or achieve the desired behaviors. Here, it's more difficult because system one habits require other strategies. And I talked about how you can try to disrupt habits, but it's clearly a more difficult situation than the first one. Here, we can maybe foresee that leadership strategies, but still an existing culture may be difficult to change by targeting individuals. And here, collective non-conscious habits which we are not aware of that exist in different social groups, of course, they can be very difficult to change. And wrapping up. So the key here is that views on behavior change differ depending on the theoretical perspective. And a different perspective might not be right or wrong. A theory might not be right or wrong, but it might differ in terms of applicability and ability to contribute to our understanding. Each perspective has its limitations, when viewed from other perspectives. And importantly, for implementation science, is that they imply different strategies. And I think that understanding key principles is important for implementation research and practice. Because knowing that habits might be part of that the behaviors you want to change are very much based on habits is important, or that they're very collectively influenced by a culture in a profession, for example, because that implies that the strategies we might use in other circumstances might not be efficient at all. So I think I have 11 minutes left. So maybe I stop sharing and we can have a discussion.
That's wonderful. Thank you so much, Dr. Nelson. This is really eye-opening. And I'll reach out to you for the implementation science course because you mentioned that it's also like capable to attend the course virtually. Really love that idea. And to follow up, we will also collect the books you mentioned in your talk and offer the links for the audience. One quick question is related to the two systems as well as how AI would change it because AI potentially would enable us to have an assistant which can be analytical, fast, and deliberate. So I want to hear your thoughts regarding how the new technology would change the theory as well as the implementation strategies by using AI.
Yeah, those are good questions. And I think we will have to do research and see, because I mean, I use AI some of these when I do writing, and I think if I'm sort of habitual, I mean, I guess we all are in how we write or phrase things. I think it is sort of provides some sort of disruption, sort of road bumps. It makes me think maybe this is a better way of writing it. So I think it will have huge impact, and probably also in healthcare. It will probably. I mean, the social cognitive. We do research where we see that they become an extremely important second opinion. Where you learn from it. So I'm sure it can be both the social cognitive, that you learn more, but it can probably also make you aware of some habits or biases that you might have. So that's a good research question, which we should look into. I have a colleague who's looking into how AI influences the profession's role, because it might, I mean, they could benefit from AI in different ways. So I think there are many issues now with AI that are worth looking into, definitely.
That's wonderful. And information for the audience. Dr. Nelson also had recent publications on the topic of AI. If you're interested in that, please check it out. And in the future, we can also organize the AI relevant topics as the in-person event at UW. And Patricia, would you like to unmute yourself and ask your question?
Sure, thank you. Thanks so much, Dr. Nilsen, for an insightful presentation. If I understand well from your early part of conversation of your talk, you alluded to the fact that financing only creates short-term rewards. And if that is the case, what does it mean for all the performance-based financing that we have sometimes in the health sector? Thank you.
Yeah, that's also a good question, because it might in some cases be highly efficient, but the empirical findings I have is really saying that you need to combine it with something else, because we've had it that you, for example, if you prescribe this or that many physical activity on prescription, you get this or that amount of money. And then they withdrew that and put it on some other task. And they could clearly see that people really followed the money. But maybe you need to complement it with other strategies so that you really see the value in it. So I shouldn't be too sure about how it works, because it seems to be sort of authorities like to use it. Politicians can say that we're putting this or that amount of money on some problem. But probably I would say that, and I guess that's a challenge of implementation research, is that combination of strategies are usually most efficient, but research is sort of very, reduce everything so we can isolate and do research on one strategy at a time. But yeah, I don't have a definitive answer. It could work, and it would be really interesting to see if are patterns when financial incentives work better or worse. So that's another research question, I think.
Thank you. Thank you very much.
Thank you, Patricia. And there is a question in the chat by Megan Cole. She said that, to me, a key takeaway from this is that we need to be designing interventions and strategies that address both individual and collective aspects of behavior. Do you have recommendation for designing those studies to capture meaningful outcomes?
Yeah, I totally agree. I think there's a sort of dilemma that what might work best in practice might oftentimes be more challenging to do the research on. And I think that's unhappy, but research is based on simplifying, reducing, isolating to check things. And we really, evidence-based practice and implementation research sort of emerged from medicine. And in medicine, you can sort of test, you can isolate and test, and you can do RCTs on individuals. Here, we sort of assume that we can use similar approaches, but I would say that this is much more social science, where everything is connected. So it's a good question. I don't really have any recommendations, but I always think that, going through the literature and how have other approached this, and if it can be applied to one's own case, or it's not easy. But I think in the quality improvement we talk about bundles, and a bundle could be several strategies. Probably most efficient, but not always perfectly easy, because also research, we need to be transparent. So what was in this bundle? And say that there were 5 strategies, then we could ask which strategy was most key, but sometimes it's the combination of strategies. So you touched on an important challenge, I would say.
That's wonderful. And along the line of thinking related to bundles in the coincidence analysis, they do try to understand about the minimum essential bundle. That is very interesting. And for any of us, if you are interested in thinking about new study designs, and then coincidence analysis will be a good one to explore. We also have another question from Kirsten West. Kirsten, would you like to unmute yourself and ask your question orally?
Yes, hi. I was just, you had mentioned how collective behaviors are deeply rooted in culture. And when I think about like public health mandates, what if they like directly oppose certain cultural like behaviors? I'm wondering how we can kind of navigate like ethical principles that surround implementation strategies and public health mandates and ensuring that we're not overriding some cultural values and behaviors as well.
Yeah, that's that's another challenge. I think that we need this cultural alignment, but it could be very difficult, I think. And I think, yeah, actually implementation science is a bit sort of, you can become pessimistic when you do this research because there are rarely success stories. That there are many challenges to achieving good results, and I think ignoring culture or thinking that people make their own individual decisions is one mistake. If the culture was not aligned with what you try to implement, I think you're likely going to not get the results you hoped for. So how can we navigate? Yeah, I always think to be transparent, put things on the table, but yeah, you have really good but challenging questions, I think, because they sort of point to you could almost call it weaknesses of the field. I think, for example, we could use qualitative research, and we do use a lot of qualitative research. We cannot measure everything. But for example, we have done a multiple case study, which I thought was quite, we tried to see what primary healthcare units, what characterized those that had achieved a good, favorable work environment. And instead of going in depth for one or two, we looked at 8. And I thought that was one very qualitative, but with sort of a quantitative comparison approach. So I think more of that. I also think qualitative is required if you want to know the how and the why. We're sometimes fixated by measuring things and as if the figures are sort of the truth, but usually I think they only inspire more. You want to know why this result emerged, etc. So I'm an advocate for, I would say, mixed methods if possible.
Great.
Thank you.
Thank you so much for all
Yeah.
the participants asking questions as well as attending this webinar. And thanks again for Dr. Nelson to conveying those 2x2 models to us. Really appreciate that. And we are going to conclude our webinar. And Dr. Nelson, Kuku, please stay in the room and we are going to debrief a little bit and plan for our next event. Thanks, everyone. Hopefully, you'll enjoy the rest of your day and the new week. Thanks.